afternoon, and we welcome you to IAPCON 2022. And this is the first session of IAPCON 2022, and we hope that it will pave the way for a beautiful session that we are going to have over the next 3 days. In the first session, we are talking about creating synergy, and this synergy is between oncology and palliative care. And this is where I would welcome our moderator for this session, Dr. Deepshika Jain, who's an anesthesiologist at Bhagwan Mahavir Hospital. And she will introduce the chairpersons, who in turn will introduce the speakers of today. So welcome to IAPCON 2022.
Thank you, ma'am. Good afternoon, all. I welcome all of you in IAPCON 22. Now I like to welcome our honorable chairperson. I welcome Dr. Rajgovind Sharma, sir. He is professor and head in Department of Surgical Oncology in Shri Ram Cancer Center, Mahatma Gandhi Medical College, Jaipur. He has 35 years of experience. He started MC Surgical Oncology at SMS Medical College, Jaipur. Welcome, sir. I am pleased to introduce Dr. Kabindra Bhagwati, working as Medical Officer in Palliative Medicine and in charge of Department of Palliative Medicine in Dr. B. Bora Cancer Institute, Guwahati. He has 22 years of experience. He is one of the pioneers to start palliative care services in Northeast India in 1999. So now I request our chairpersons to please introduce our speakers.
A very good afternoon to all of you, and welcome to IAPCON 2022 Jaipur. And I would like to thank Dr. Anjum and her team, Dr. Bidda and Dr. Deepshika, for starting with such an important aspect of palliative care in this conference. We have got three eminent speakers in this session. The first is Dr. Hemant Malhotra. He is the director of Shri Ram Cancer Center and professor and head Department of Medical Oncology, Mahatma Gandhi Medical College Hospital, Jaipur. He has got more than 30 years of experience in oncology practice and research. His areas of interest are lung and breast cancer, hematological malignancies, transitional research, and clinical trials. He is and was president of several organizations like Indian Society of Medical and Pediatric Oncology, Teenage and Young Cancer Foundation, Immuno-Oncology Society of India. He is the chairman of Multiple Myeloma Treatment Guidelines Committee of ICMR. He is the member of Oncology Project Review Committee, ICMR, and he has got more than 200 publications and presentations in national and international journals as well as in conferences. So his topic of he will be talking about advances in systemic anti-cancer therapy. What does the palliative care physician need to know? So over to Dr. Hemant Malhotra, sir.
Hello, everybody. My name is Dr. Hemant Malhotra. It's my pleasure and honor to be part of this extremely important conference. And my brief today is to, bridge this gap between the palliative care physicians and the oncologists when we are talking about a patient who's terminally sick and where the intent of treatment is palliation. So I bring you greetings from the Mahatma Gandhi Medical College Hospital in Jaipur. And let me introduce you to our common enemy, cancer, which is also known as the emperor of all maladies and the king of all terrors. So this is what I intend to do in the next 15 or 20 minutes. A few slides on the introduction, then the goals of chemotherapy, the clinician. And hello, everybody. My name is Dr. Hemant Malhotra. It's my pleasure and honor to be part of this extremely important conference. And my brief today is to, bridge this gap between the palliative care physicians and the oncologists when we are talking about a patient who's terminally sick and where the intent of treatment is palliation. So I bring you greetings from the Mahatma Gandhi Medical College Hospital in Jaipur. And let me introduce you to our common enemy, cancer, which is also known as the emperor of all maladies and the king of all terrors. So this is what I intend to do in the next 15 or 20 minutes. A few slides on introduction, then the goals of chemotherapy, the clinician and the patient's perspective, what benefits we expect from systemic anti-cancer treatment, how to make this decision, which patient should receive anti-cancer treatment, which patient should receive only best supportive care, integrating everything into the patient care for optimal outcomes, a snapshot of the future prospects, and finally some take-home messages. So, ladies and gentlemen, systemic anti-cancer treatment has been growing with the availability of differing therapies, particularly targeted therapies and immunotherapies, when used in the palliation of cancer. Treatment goals, both for palliative care physicians as well as treating oncologists, remains to improve the patient's quality of life, to improve the patient's symptoms, and if possible, to increase the quantity of life. The role of improving both quantity and quality of life is continuing to evolve. So when I started oncology some 30 years back, we had very few medications, and the only treatment for cancer was chemotherapy. And we know that chemotherapy, in addition to benefiting the patient, certain patients, it also harms the patient. There are lots of toxicities. But now with the availability of new targeted agents like the tyrosine kinase inhibitors, like the monoclonal antibodies, and the immunotherapies also known as checkpoint inhibitors, with or without palliative chemotherapy, there has been a substantial progress, and all this whole gamut is known as systemic anti-cancer therapy. And because there has been a surge in the number of drugs available, the number of approvals which have been made world over for these agents, and the number of patients who receive these drugs have also increased. Now we know that for a stage 4 patient or a patient who has recurrence of the cancer, the goal of chemotherapy is disease palliation. So, the goal again is to help patients live both longer and, even more importantly, live better. So, systemically given anti-cancer treatment or palliative chemotherapy, it decreases the cancer burden through cancer cell kill. It reduces the size and the burden of the cancer, and because of this, it improves the symptoms. It sometimes changes the natural course of the disease and prolongs life. But this comes at the cost of potential toxicities in terms of, and it also comes at the cost of expenses in terms of hard money and time invested in undertaking treatments. Now, unfortunately, neither the benefit is guaranteed nor the toxicity is guaranteed. So there always remains an uncertainty when you give systemic treatments. So, but you also have to remember, and we also have to remember, that risks of having more side effects than symptom relief is rare. It can and it does happen in some patients, and it is difficult to predict. So this balance between chemotherapy and palliative care, or palliative chemotherapy or palliative systemic anti-cancer treatment versus only best supportive care, this is a very delicate balance which needs to be achieved for the best outcomes of the patient. And what is foremost in this, careful communication between the patient, between the oncologist, between the palliative care physician regarding the risk benefit of the systemically administered treatment is very, very important. Some guidelines by national and international societies have been provided to us but still applying these guidelines remain a challenge in clinical practice. It has been found that patients' understanding of the illness, his or her prognosis, and the clarification of treatment goals is very important so that the patient and the patient's family can be an equal member in shared decision making. So there is a very important need for assisted and shared decision making, which addresses both the patient and the caregiver's desire, which also, in addition to controlling the patient's cancer, also addresses his or her psychological and physical care needs. So as I said, the cancer treatment balance, particularly for a patient in which the intent is palliation and the general condition of the patient is not very fit, there is a very delicate balance between benefit and toxicity. Systemically administered cancer treatment versus supportive care have to be balanced very carefully. And I have no hesitation in adding over here that best supportive care has to be given to all patients. Some patients may benefit with additional systemically administered cancer treatment. So whether not to give this and only to give this, that is the balance which a good clinician has to strive for. You know, there is this difference in perspective, the clinician's perspective and the patient's perspective. And you know, this cartoon just illustrates this for patients who have acute myeloid leukemia, elderly patients, infirm patients. You can give them a whole menu of treatment, starting from intensive treatment to just supportive care. And you can just ask the patient to pick one, and the patient is really, truly confused. So, and this perspective is extremely important, and this, you know, nobody is wrong. The patient is also right. The patient is always right. The palliative care physician is also right. The treating oncologist cancer patient. So this is that conflict between the clinician and the patient perspective. And the key to this, the key to good shared decision making relies on understanding of what is valued by a patient and the patient's caregivers. Individual personal factors are not always predictive. The patient with a terminal illness may value a small chance of benefit more highly than the staff who administers the treatment, and vice versa is also true. So this is the and there might be a difference in perception between the patient and the patient's relatives. So this is extremely pertinent in our country, where the relatives want to preserve the patient's money while the patient wants to spend his or her money on his or her health care, even if that buys him only 2, 3, 4, 5 months of life. So this has to be very carefully understood. There was one study from England regards to attitudes to chemotherapy, and it was found that patients would accept a toxic treatment for only one chance of cure. They would accept a toxic treatment for only 10% chance of symptom relief, or the chance of prolonging life by only as little as 12 months, while the bar for physicians and nurses who are administering them this treatment is much higher, 50% for cure, 75% for symptom relief, and at least 2 years for survival. So patients may agree to experimental therapies. Patient may enroll for a phase 1 study, early phase clinical trial, accept a mortality rate of 10% with no degree of certainty of benefit. So this has to be borne in mind that individual and personal factors in patient decision making are extremely important. So current UK guidelines, very broad framework, advises against systemically directed cancer treatment if the patient is expected to die within a month. American guidelines say that these treatments should not be given if the patient is just 2 weeks from death. And you would appreciate that it is extremely difficult to estimate accurately how long the patient has to live. So, but it has been observed that patients receiving treatment near the end of life are more frequently admitted to hospital, less likely to die at home, and less likely to enter hospice care. And some reports are there which suggest that increasing number of patients receive ongoing treatment even when they are very near the end of life. So this again is something which needs to be fixed. So one of the strongest indicator of a patient being close to their terminal phase is the performance status, which is a measure of functional capability, which all of us know. And systemic anti-cancer treatment is usually not recommended for patients who have a performance status of 4. Many occasions when both short predicted prognosis and poor performance status may not deter the patient or the cancer physician from systemically administered cancer treatment. So there are some situations, and these situations are gradually increasing with the availability of targeted treatment, with the availability of immunotherapy, which have much less toxicity as compared to standard chemotherapy. Say, for example, if I have a patient of small cell lung cancer who has liver metastasis and who is in performance stage 3 or 4, chemo naive patient, not received any treatment in the past, this patient has a 90% chance of responding to just oral etoposide. So hard and fast rules are difficult to make, and each and every patient has to be individualized. And as I said, with the development and availability of targeted treatments, just one pill to pop with very minimal toxicities, with the availability of immunotherapy, which is much less toxic than chemotherapy, it has its own specific toxicities, but the number of patients developing grade 3 or grade 4 serious adverse events is much less. So this choice has become even more complicated and difficult with the availability of these options. And there again, as I said, the ASCO consensus groups, they have met, they have discussed all these things, but they have not been able to come to a conclusion. So quantifying benefits of systemic anti-cancer treatment, it's not simple. It's not a mathematical or a physical formula, but there have been attempts that trying to scientifically categorize for which patient systemically administered anti-cancer treatment can be given. And they, of course, as we've already mentioned, the goal of this is to improve survival and improve the quality of life. Data has confirmed that the benefit of traditional palliative chemotherapy in some tumors, particularly at diagnosis, even if they have stage 4, even if they have performance status 2 or 3, sometimes even for cancers like breast cancer, colorectal cancer, lung cancer, pancreatic cancer, they may benefit from these treatments. So some other cancers like melanoma and renal cell cancer, which have been traditionally resistant to chemotherapy, treatment options have been limited. When I started oncology 30 years back, we had no treatment for stage 4 melanoma. We had no treatment for stage 4 renal cell cancer. But now the landscape has completely changed with the emergence of personalized medicines. Targeted treatments with or without immunotherapy, is now the standard of care for hard to treat cancers, like a combination of BRAF inhibitors and immunotherapy in melanoma, and a combination of a tyrosine kinase inhibitor with immunotherapy in renal cell cancer is really increasing. Just to show you a snapshot, this is the treatment of melanoma with a BRAF inhibitor and a checkpoint inhibitor immunotherapy. This is the immunotherapy and this is the BRAF inhibitor. And you can see that almost 100% of the patients show a response and a significant number of patients show a complete response. So, situations like this are, happening with more treated with immunotherapy. Now, how do you decide? It is really truly tough to decide as to how to proceed, and informed decision making is extremely important in this. Excuse me. And this has to be a shared decision making between the oncologist, between the patient, and between the caregivers. Accurate estimate of survival again is important so that you can avoid systemically administered cancer treatment in patients who have just a few weeks to live. Lots of associations, the European Association for Palliative Care, have identified different factors which correlate with the patient survival. And this includes a combination of performance status, symptoms of cancer, anorexia, cachexia syndrome, delirium, dyspnea, and biological factors like leukocytosis, lymphocytopenia, and C-reactive proteins. And a number of other palliative prognostic scoring systems have been devised, which helps you to predict the survival of the patient and choose which patient in which chemotherapy or immunotherapy or targeted therapy should be used, and which should be the patient for only supportive care. An integrated approach to palliative treatment is very, very important in spiritual health. Integrated approach is extremely crucial, and with the availability of the newer therapies, this has become even more difficult. Palliative care should be offered to every patient who's diagnosed with stage 4 cancer, with or without systemic treatment. So the systemically administered cancer treatment and palliative care, there has to be a cooperation between both the modalities rather than a confrontation. So my key take-home messages for you are: the landscape of therapeutic options for cancer palliation has dramatically changed over the recent years, with many treatment options now being available, which have a high response rate, which have an improvement in survival and changed toxicity profile. And this delicate balance between benefit and toxicity has to be maintained. Increasing number of patients are receiving chemotherapy in the last weeks of life, which should be avoided. There is a disconnect between patients and doctors, and this needs to be worked on. There has to be an emphasis on communication, honesty, and frank discussion on benefits versus the risks. A multidisciplinary approach to cancer palliation, which not only includes systemically administered treatment, but also palliative and hospice care from day one, have to be in place. And a free and frank discussion and joint decision making between patient, treating oncologist, and palliative care physician needs to be done. Sometimes this choice is difficult, and it is more of an art than a science, and we need to develop this art, all of us oncologists, all of us palliative care physicians, for the best outcome of our patients. With that, I'd like to thank you very much. Have a wonderful day.
So thank you, Dr. Hemant Malhotra. You have explained nicely about the systemic anti-cancer therapy, and you have touched many vital points and given useful information for the palliative care fraternity. Our next speaker is Dr. Deepa Susan Joy Philip. She is an assistant professor of Department of Medical Oncology, Regional Cancer Center, Trivandrum. She has got 8 years of post-DM experience in oncology practice. Her areas of interest are geriatric oncology, hemato-oncology, and she was the gold medalist in DM Medical Oncology from Tata Memorial Center in 2014, and a gold medalist in MBBS 2 from Kerala University. Over to Dr. Deepa Susan Joy Philip.
Distinguished delegates, dear colleagues, friends and students, very good afternoon to you all. First of all, let me express my most sincere thanks. Thanks for hope. Hope for you, for me, and for all of us. I sincerely hope that it's not a hardship, ordeal, and punishment in the evening for you. It's an honor, opportunity, privilege, and experience for me. to help oncology patients everywhere. With early palliative care in hemato-oncology. Myself being a webinar illiterate doctor, faced with the top 3 questions of 2020, ever since the time this talk was assigned to me, this was my state of mind like a nursery kid preparing for LKG entrance. Don't worry, I'm not here to hammer in all those facts and figures into your brain. We will not have a Bahubali Thali like this. The intellectual menu for today is going to be very short, sweet, and simple. Let me share with you an important challenge in oncology. Early palliative care in hemato-oncology. We have 5 points only for discussion, which will be discussed in exactly next 15 minutes. My first point is thanks. Second point is my dream or vision of an ideal model of palliative care in hemato-oncology. Third point, what is the evidence to substantiate it? Fourth, what is the present reality? Fifth, what are the barriers and potential bridges? The dream or vision of an ideal model. Dream is not that which you see while sleeping. It's something that does not let you sleep. Now, let me explain with a very simple example. Okay, here we have a driver A. He's very smart and confident that nothing bad will ever happen to him. See, he's driving with his eyes closed. He is not bothered about any comfort features like AC or seat belt, nor is he bothered about any safety features like seat belt or airbags. This is how the ride is going to be, and this is the expected outcome. Now let's look at this driver B. He is smart and confident, but at the same time, he is well prepared as well. He has a hopeful and realistic attitude. He wants to ensure maximum comfort while traveling. At the same time, he is prepared in case things do not go as planned. Though the ride is bumpy, he is prepared for it. So, if you have to choose between this driver A and driver B, whom would you choose for your ride? It's obvious that anyone logically will choose the driver B with the hopeful, realistic attitude with the comfort and safety measures. The second question, when would you think of safety and comfort measures? Is it right from the start of the journey or is it towards the end of the journey? Naturally, we will think of integrating the comfort and safety measures right from the start throughout the journey so that our goal of a safe journey is fulfilled. Coming back to our real life scenarios, the journey of 1,000 miles begins with a single step. Let's think of our journey with our dear patients. Do we want to be like the driver A with a real hopeful attitude that nothing bad will ever happen to me? Or do we want a hopeful and realistic attitude where I want to ensure maximum comfort to my patient during the journey, and I also want to be prepared in case things do not go as planned, so that the ride is more comfortable with less distress at the end of life. Just as the word pallium means to clock, let's cloak or blanket our patients with an extra layer of support and comfort throughout the journey of life. Let's hope, wish and pray that the oncologist and the palliative care physician will work together hand in hand to fight a common enemy. As a team, together everyone achieves more. A team with patient at the center. A team and a philosophy that is independent of diagnosis and prognosis to provide holistic total care. Palliative care starts as close to diagnosis as possible and gradually increases in dosage with time. To provide a loving continuum of care where there may be an end to cure but definitely no end to care. To summarize my first point, let's count days and make every day count with early integrated palliative care. How early is early? A very nice definition of time. Time is slow when you wait. Time is fast when you are late. Time is short when you are happy. And time is long when you feel bored. I hope I have not bored you so far. That takes us to the third point. What is the evidence? We live in an era of evidence-based medicine. This is the famous study by Jennifer Timmel published in NEJM way back in 2010 on early palliative care in advanced lung cancer patients. In this study, patients of metastatic lung cancer were randomized into two groups. A group which received early palliative care integrated with standard oncology care, and a second group which received standard oncology care alone. Quality of life, psychological distress, healthcare utilization were measured in this study. It showed an improvement in quality of life and surprisingly a survival benefit of 3 months as a secondary endpoint. In short, early introduction of palliative care in metastatic lung cancer patients adds life to days and days to life. Then we had a tsunami of randomized trials in malignancy. This finally led to the American Society of Clinical Oncology Clinical Opinion Statement in 2012. And with an update in 2017. What is the most effective way to care for patients with advanced cancer symptoms? It's with early, concurrent, integrated palliative care. Evidence-based, benefit outweighing the harm with a very strong strength of recommendation. That was in solid tumors. What about in hemato-oncology? Our first evidence is a randomized control trial in patients during hematopoietic stem cell transplant. 160 stem cell transplant patients randomized into two groups, integrated palliative care and standard transplant care. This study showed improvement in quality of life, psychological distress, and physical symptom relief. The second randomized control trial was on patients with acute myeloid leukemia. A total of 160 high-risk AML patients with a median age of 64 years, randomized to two groups, integrated palliative care and standard oncology care. These were the results. To summarize the benefits, 1. Improves quality of life. 2. Decreases physical distress. 3. improvement in psychological distress? Truly a high-touch technology in this era of high-tech technologies. Early end-of-life care discussions and very less chance of receiving chemo in the last days of life. That takes us to the fourth point. What is the reality at present? The diagnosis of cancer is a death sentence for the patient and for the family. So let's see what is the physical distress of our patients. The symptom burden of patients with hematological malignancies. 70% of patients had significant symptoms, most common being fatigue. Now, what about psychological distress? Even the most curative Hodgkin's lymphoma has a psychological distress burden comparable to that of advanced lung cancer. Now, the most interesting, what is the prognostic understanding of our patients? 90% of patients expressed the desire to know prognosis. Unfortunately, prognostic discussions happened in only 50% of situations. The most interesting, accuracy of prognostic perception. The patient's perception in 78% of situations was discordant and more optimistic than that of the oncologist. So, this over-optimistic perception led to inappropriate decisions and aggressive end-of-life care. In short, there is a definite unmet need for palliative care. So, now let's see if our patients are appropriately referred for specialist palliative care. As you can see from this meta-analysis, the risk of palliative care referral in hematological malignancies is 0.46, meaning if I am diagnosed with a blood cancer, my risk or chance of being referred to palliative care is less than 50%. Now, what is the interval between the palliative care referral and death? Are patients referred early or are patients referred late? Let's see what this evidence tells us. Let's concentrate on blood cancers. The interval from palliative care referral to death is less than a month. Palliative care referrals are either very late or never. So, what happens because of that? This is a systematic review of the place of death. Are patients destined to die in hospital? As this forest plot shows, if I have a blood cancer, my chance of dying in the hospital is twice than that of other malignancies. When we all know that home is the ideal place for anyone to die, surrounded by near and dear loved ones, these patients are destined to die alone in hospital ICU, receiving chemo in the last days of life. This is what happens in our day-to-day practice. In short, palliative care in hemato-oncology at present is either late or it is never. So, we have our head telling us what to do, evidence-based medicine. We have our heart telling us why to do, emotion-based medicine. And we have our hands telling us how to do it, that is experience-based medicine. Why there is a mismatch and imbalance between our head, our heart and our hands? That takes us to the fifth point of barriers and bridges. The first B in the acronym barriers is biased gatekeeper. Especially hemato-oncologists, we have a long treatment course, lasting for months to years together. So it's natural that we have a special kind of bonding which becomes more like a possessiveness or ownership of the hemato-oncologist with the patient. The oncologist feeling that I am self-sufficient, I can play a double role. Next is the oncologist washing his hands off like Pontius Pilatus in the Bible. Life is what happens when we are busy planning other things. Unexpected, unpredictable change in disease trajectory. R for resistance of patients and family. Illness unique needs like recurrent transfusions and antibiotics. Equating palliative care to end-of-life care. Referral issues. System-based barriers of materials, manpower and minutes. That takes us to the last point of bridging barriers. Here we can see a very interesting bridge, a bridge that is flexible and adaptive, like the kind of bridges that we need in our life as well. Bridges, BRIDGES. It will be discussed beautifully by my dear friend and colleague Dr. Avinash. Just for a bit of lateral thinking, can you identify this very famous bridge on the right? And what is the unique color that is used to paint this bridge? That's California's Golden Gate Bridge in international orange color. So let's hope, wish and pray that the oncologist and the palliative care specialist will work together as a team with mutual trust and training of the oncologist in palliative medicine and training of the palliative care specialist in hemato-oncology, like this beautiful paper on top 10 tips for palliative care clinicians. No one cares how much we know unless they know how much we care for them. So, with early palliative care in hemato-oncology, diagnosis of cancer is never again a death sentence. Let's hope to flatten the COVID curve and also the webinar curve, and we can meet in person soon. To cure sometimes, but whenever we can, improve almost always, to comfort and console always and always, but never ever harm our patients. To the fond memory of my mother, for whom we couldn't add many days to her life, but we could definitely add a lot of life to the days that she had. Many thanks to palliative care team. Past is history, future is mystery. Today is God's special gift, and that's why it's called the present. Requesting your GPS. Guidance, prayers and support in my journey ahead as an oncologist. When we substitute we for I, illness becomes wellness. Thank you for your patient listening. Any questions, comments, concerns, criticisms, all are most welcome. Thank you so much.
Thank you, Dr. Deepa Susan, for elaborating nicely on the problems faced by the hematolymphoid malignant patients and how the palliative care service can help them. Our third topic is on challenges with integration and early palliative care in the Indian scenario. And the speaker is Dr. Avinash Bonda, He is an associate professor of Department of Medical Oncology, Homi Bhabha Cancer Hospital and Research Center, Visakhapatnam. He is a member of ESMO, and European Hematology Association. He has got 9 years of experience in this field. His areas of interest are hematological cancers and stem cell treatment. Over to Dr. Avinash Bonda.
Yeah, I'm ready. Okay. Very good afternoon to all of you. At the beginning, I would like to thank the organizing committee of IAPCON for giving me this opportunity for sharing this important talk. So I'm here to talk about the challenges with integration and early palliative care in the Indian scenario. So WHO actually recognizes palliative care as a holistic approach to the care of patients and their families facing life-threatening or long-term illnesses, and WHO recognizes its role very early in the course of disease and perhaps concurrently with disease-modifying treatment. Now, cancer patients constitute a part of this long-term treatment or long-term illnesses, where ASCO states that in cancer patients, palliative care is a multi-pronged approach. It addresses the various aspects of rapport building with the patient, addresses the illness understanding and prognosis, assessing the coping and support mechanisms of the patient and the families, and it definitely aids in treatment. So we have come a long way since we ever began in the 12th or the 20th centuries with palliative care. These two recent, the inauguration of the national program in palliative care and multiple other important developments in palliative care field, even in the Indian scenario. But we still have a long way to go. Now, palliative care is a key index of high quality patient-centered care, without doubt. It is a multidisciplinary team approach outpatients, and I personally feel that all of them are successful. The distress of the disease or the suffering is what is the key feature, or what is the center point in which around which the palliative care has evolved. And the most important feature of palliative care is that it just takes care not only the patient but the caregivers as well. And it always mutually reinforces, or rather it reinforces the oncological treatment and the life prolonging treatment, if you call it. And it is a mutual reinforcement between the primary palliative care physician and the treating oncologist. The important aspect of this end of life care, which is perhaps an important part of palliative care, it perhaps makes it more cost effective and efficacious. So this is what I tried to put forward here with respect to the various issues that we see life, like acute pain, dyspnea or delirium, and certain chronic underlying issues like depression or anxiety, along with existential, spiritual or psychosocial issues. Now, this is a spectrum of palliative care management. Now, the rationale for the talk today is to actually emphasize on what is known as early palliative care, perhaps the traditional palliative care. In fact, I'm afraid that this is what the concept of palliative care is. Many physicians even today across the world and the country, that palliative care is something which is deemed to be towards the end of life, or when you have exhausted all so-called lines of therapies. So palliative care is something which is synonymous, or which is, which reflects something like palliative care is something which is synonymous of life care, but that is not the concept, or that is not the notion that needs to be brought up. So this early palliative care is what is we are looking at, because the palliative care, integration of early palliative care along with the life prolonging treatment or along with the systemic therapy, you can see that as you can see a difference between how the patient's diagnosis, integration of palliative care at the time of diagnosis to death, because palliative care is a continuum of care, or it's a spectrum of care along the illness of the patient. So it makes the patient live well as well as die well. One of the most important, or perhaps the primary goal of palliative care, is to help patients live as well as possible for as long as possible. So the primary objective of palliative care is improvement the life of patient, to ease the distress of the patient, to explore and perhaps address the concerns of the caregivers, their family, and well-being of the patient. So it makes the life of the patient well, as well as it makes the dying comfortable and distress-free to the patient's families. Now, over the past few years, there has been a notion, or there has been a review of literature, or there has been numerous publications or numerous dearth. So there has been an increase in what is called as an improvement of survival as an important concepts, or rather improvement of survival being considered as a primary goal of early integration of palliative care. I beg to differ from this, because improved survival is only a welcome side effect. It is not the primary goal of early palliative care. It is definitely welcome, it is definitely beneficial, but I say that it is not necessary, because the primary goal of palliative care is to improve the quality of life of the patient, and to make death comfortable, or to make death distress-free for the patient as well as the patient's relatives or the patient's family in concern. So with that, these are the two important publications which I could get, which actually reflected improvement in the survival of the patients. What is important here is that none of these studies have the overall survival as the primary outcome or the primary endpoint. It is one of those what you can call side effects which just emerged, because the primary outcome of any palliative care trial would actually be a improvement in quality of life, the distress scales or distress relief. Yet another overall survival analysis which actually showed an improvement in overall survival in these patients who have been who are with metastatic cancer and who have been assigned with electronic patient reported symptom monitoring. So this is one more important point that I would like to make, that this improvement in the so-called survival, or the so-called improvement in survival, is only a welcome side effect, a very beneficial side effect, of course, but it is not the primary outcome of early palliative care. So these are again a couple of studies which I tried to put forward here for emphasizing the same, that distress, the patient satisfaction, the end of life care, these are other perhaps more important primary outcomes. Definitely improvement in survival is a very lucrative and very attractive concept of early palliative care, and definitely I too use it in my daily practice in order to rather coax my colleagues, or coax my friends, and then other colleagues in the department to actually seek palliative services way early when you're starting your treatment. Now, how early is something that is of a debate, because ASCO defines it as at the time of diagnosis for all advanced lung cancer, definitely advanced lung cancer, and perhaps all other advanced. Look at it, it is very patient specific, it is very disease specific, it is very symptom specific, or rather, it all takes into account the disease burden and the symptom burden of the patient. Sometimes it is very important that you first take early palliative care into account, or start early palliative care and then start your disease-directed or systemic therapies. Because once you have significant stressors with the diagnosis of the disease, along with the disease burden and the patient, so when you ask for palliative care, when you seek palliative care, when you initiate it, then the patient will be able to cope with cancer treatment better. It is definitely early. Now, this can be actually decided on patient-to-patient basis based on their symptom burden and the disease burden. So, primary palliative skills which every oncologist should possess, because this is actually one of the important gaps between the primary palliative care and the specialist palliative care. And this, so there and disease prognosis of the patient, and perhaps certain topics like the topics of death, the topic of resuscitation, the topic of ICU shifting. So these skills are some skills which are primary to an oncologist. So the oncologist can act as a primary palliative care physician, and this is what is called as its more sustainable model. So the primary palliative care is perhaps the skill set of the treating oncologist, and then we can actually take help from a specialty palliative care where management, complex issues like anxiety, grief, or existential distress. Suppose we have certain conflict resolutions between the families or with the staff and the families. And whenever we talk about fertility and addressing the issues, especially this is regarding the end of life care, there comes the role of a special palliative care. So this primary palliative care, and perhaps the role of a primary palliative physician should be taken up by an oncologist, or should be taken up by the treating oncologist himself or herself, and that is the need of the hour today. So these clinical services are actually delivered by all the clinicians so that the patient's outcomes or the patient's quality of life is improved. So another figure actually depicts the same. We have the care given being refined over a period of time towards the end of life. But what actually happens, this is perhaps the true perspective, is that there is a definitely lack of enthusiasm and perhaps awareness among my clinical colleagues and among oncologists per se regarding this early palliative care. Of course, this is regarding, of course, all routes where the training curriculum, even my oncology fellowship program did not have a palliative care training, did not have a palliative care posting during my oncology training. So this is something which is concerning, or this is something which is the need of our. Per se, we have take care of our patients, and by various means, by continuing medical education, by revisiting our palliative teams, taking sessions from the palliative care physicians. So this is how we need to train our oncologists per se. This is a very, very important aspect of addressing the primary palliative care. There is something called lack of time, and perhaps this lack of time in your office, in your hospitals or your office to address the patient issues is something which needs to be addressed. Because these effective communication regarding the diagnosis, the prognosis, the goals of care, the intent of treatment, the end of life, the hospice, all these effective communication skills require training, because none of us are born with them. So the need of I would actually prefer is that we should have an effective palliative care training or palliative care posting for all oncology fellowships or all oncology training programs. Only then we can actually ensure that basic palliative skills or the basic palliative care is actually met with. The other important, of course, the challenges are present. You can see here, these are the various challenges at personal level, because the attitude of the patients, their beliefs, the cultures, the skill set, their education level definitely varies, and ultimately this reflects in their acceptance. And we have an organizational level procedures, organizational level structures. Then the health system as such, the workforce, definitely we have a shortage of workforce. The accessibility to the drugs is another important, the resources and the properly trained personnel and the proper training itself. And ultimately everything is the bottom line of everything is the funding. So these are certain challenges which we have with respect. And as I told you, the most important or the topmost concerns are lack of this clinical knowledge or lack of the skill set for the oncologists, and lack of enthusiasm for palliative care by the oncologist. Later on comes the role of your communication skills, or your legislations, the assessment tools, and so that the lack of palliative care knowledge and skill training programs during your education of oncology itself is the root cause, for this for our for the integration of early palliative care. Regarding the various barriers and the recommendations, yes, again, if we should have more consistent coverage, or perhaps a comprehensive coverage of the policies, and at the level of the primary palliative care providers, we should integrate them into the trajectory as early as possible. So these are various barriers at various levels, organizational, policy levels, at individual levels. We have barriers everywhere. But what we see is that the situation is not so grim here, because in India we have a concept of extended families, we have a community sense, and we have household help, and we have availability of support. But what is the problem in India is that the accessibility to medical care itself is an issue. The limited infrastructure in the government hospitals, and I can challenge how many of you actually have seen the palliative care department in the government general hospital. So the availability of drugs, especially opioids, is another important issue. And of course, the lack of trained professionals. So these are the disadvantages that we need to critically address. And perhaps I think over the period of time in the next few days of the conference, we could actually come out with probably problem solving concerns with with these sort of problems that we face day to day in palliative care. Of course, last but not the least, I just want to put forward this national program for palliative care, NPPC, where we try to increase the regulatory aspects, so increase the availability of the morphine or opioids, along with establishment of what is called as palliative care cell and palliative care services in district hospitals, so that they can act as the nodal centers for our patients, as well as for training the professionals in palliative care. And of course, they have this budget allocation for palliative care. I'd like to conclude saying that the early palliative care is an integral part of cancer management. It is an indispensable part of cancer management. We are actually beginning, or perhaps from an oncologist, or from my perspective as an oncologist, we are actually beginning to understand this. But we have a long way to go, because we have to train our upcoming oncologists, our residents, our fellows in actually understanding this concept of early palliative care, and to provide them with the skill set to actually manage the basic palliative skill, so that we actually can think of the specialist palliative care at a later point of time. But this gap of basic palliative care management needs to be.
Thank you, Dr. Abhinas Bonda, for pointing out the challenges in Indian scenario, and now the task has become a little bit easier for IAPC and policymakers, and also the aspirant institutes to work on it. Thank you. And I think we are running behind time, so I would like to hand over the mic to Dr. Deepsika.
Thank you, sir. So it was a very wonderful session. Now we move on to the panel discussion. I welcome all our panelists. I'm pleased to introduce Dr. Sarbani Ghosh Laskar. She is radiation oncologist, professor in Department of Radiation Oncology, Tata Memorial Hospital, Mumbai. She has 22 years of experience, more than 180 publications she had. Welcome, ma'am. Now I welcome Dr. Kalpana Balakrishnan. She is professor and HOD in Department of Anesthesia, Pain and Palliative Care in Cancer Institute, Adyar, affiliated to Regional Cancer Center, Chennai. She has 33 years of experience in anesthesia and 11 years in palliative care, and has over 20 publications. Welcome, ma'am. I welcome Dr. Anshika Arora. She is Associate Professor in Surgical Oncology and Palliative Care, Physician in Cancer Research Institute, HIMS, SRHU, Dehradun. She has 13 years of experience, and she is involved in 21 original research projects. Welcome, ma'am. I welcome Dr. Anuja Ramani. She is Associate Professor in Department of Palliative Medicine and Supporting Care, Kasturba Medical College, Manipal. She has 10 years of experience. Welcome, ma'am. Now I request Dr. Vidya to take over the discussion. Dr. Vidya is Assistant Professor in Homi Bhabha Cancer Hospital and Research Center, Visakhapatnam, and she has 10 years of experience. She is the team leader of this session. So, ma'am, please take over.
And thank you so much, Deepshika, and I thank all our speakers today. It was wonderful to hear their views. And our panelists today are from surgical oncology and from radiation oncology. So having the entire spectrum of medical oncology, surgical oncology, and radiation oncology, and our palliative care team who are already here. I can see Kalpana and also Anuja. So we hope to make this panel discussion move from theory into our practice. So may I just share my screen now? So we thought of having this panel discussion, early palliative care. How do we apply this theory to practice? So starting with a case scenario, we have Mr. RS. This would be a common case scenario that we would see. He's 45 years old, a chronic tobacco chewer. He's been diagnosed with squamous cell carcinoma, oral tongue. Clinically, staging is T3N1. He had a post-adequate glossectomy and neck dissection. The pathological staging now is T3N3. And there is extranodal extension. So now we are at the tumor board and deciding whether adjuvant CTRT is the plan. So the points for discussion for this would probably be, I would like to start with Dr. Sharbani and with Dr. Anshika following that on how could we provide early palliative care for this patient? What would be the trigger symptoms for referral, either the surgical side or radiation oncology side? What are the different disease groups which have the highest symptom burden? And who is going to discuss nicotine withdrawal in this patient? So can we start with you, Dr. Sharbani, please?
Yeah, thank you, Vidya, for that question and for that very important situation, because head and neck cancers are the commonest cancers in our part of the world. So you have said that this is a post-operative tongue T3N3M0. By this, the importance lies in the fact of understanding early on that this patient is going to have several symptoms, and these symptoms are essentially going to be attached to his activities of daily living. So these are going to include pain, it's going to include difficulty in swallowing, it's going to include an alteration in the diet of the patient. And not only that, after surgery, the patient is going to experience a lot of change in his normal day-to-day activities as well as functionality. So considering all this, I think the role of palliative care, and if you were to equate and consider palliative care as well as attention to symptoms and provision of adequate supportive care together for this patient, because that's where we are all moving. That is, identify symptoms, attend to symptoms, provide appropriate supportive care at the right time. And of course, all this moves hand in hand to the oncology or oncological management that we have to provide this patient. So I would place it like that. So it would be attention to symptoms, attention and provision of supportive care in this patient. And therein would come the involvement of the palliative medicine specialist, because we would look as a team, as a multidisciplinary team of the surgeon, the radiation oncologist, the medical oncologist, because this is a patient who needs all three modalities of treatment, and the palliative medicine specialist also, because he or she with appropriate specialty and knowledge in that particular cancer, because I am thinking more of having a palliative medicine specialist who specializes in the management of symptoms and problems related to head and neck cancers. Because that would actually give an edge over a general palliative medicine specialist. Education or knowledge, because that person would be able to understand symptoms related to the treatment, would understand treatment symptoms related to the disease, and then the role that he or she has to play. So that is my take on what is the role or the position of the palliative medicine specialist for this particular patient. So it's an integration of supportive care, symptom attention to symptom burden, and treatment put together. Thank you.
Thank you, Sharbani. So that's a nice stepwise approach. We put the symptoms, we put the support, and then I hope we see a time when we evolve and we have, like we have disease-specific managements, we also have disease-specific palliative care. We have head and neck palliative care consultants separately. That would be
And I would really say that early integration of palliative care bend of mind for a surgical oncologist is quite good for the patient for many reasons. Some Dr. Sarbani has already mentioned. I would like to highlight a few. The first one would be physical problems like pain, nutritional issues, speech, swallowing, chewing, especially now, apart from the physical symptoms, where a palliative care physician, or if you could handle it well in advance prior to surgery itself and take on from there, the other issue which comes is distress, which is something which hardly ever we are looking for in the patient and the caregiver. So we have to actively look for any psychological distress like anxiety, depression, and if it is there, that would be a trigger to send the example, the patient could be the sole breadwinner for the family and a wife and young children. So probably the palliative care team could support them socially and financially as well. And a long-term care will definitely be needed there. So that would be another trigger for involvement of early palliative care team. Then, of course, uncontrolled symptoms like pain management, uncontrolled pain, or any other uncontrolled physical symptoms, we definitely would involve the palliative care team. Whole, I would say that early integration of palliative care from day one, since we see the patient, is a very good idea, and definitely it will improve the long-term patient and caregiver goals.
Thank you, Anshika. So as a surgeon, you feel that the multidisciplinary team is what we are looking at, and we look at rehab along with all the symptom control that we can. How much of this is actually possible?
Expecting in most major oncological centers, because palliative care is available, psycho-oncology, physiotherapy, the various nutritionists rightly pointed out, all these would be available apart from the major oncological, medical, surgical, and radiation oncology. But I do not know whether in our country only the major cancer centers are treating such patients. There are multiple areas where such patients are treated, and every patient who gets such a treatment care and should have some sort of palliative care. A big question.
Can we hear from you?
Yeah, so I agree with Dr. Kalpana. What she mentioned is palliative care team is something, it's not only about symptoms. I would just like to highlight it's an integration and coordination of care that is required there. It's not only about managing pain and managing swallowing difficulty, its psychological issues, social issues, and managing it holistically as a integrated approach. So I believe it's more of supportive care there, as Sharbani ma'am just mentioned, and very specialized to head and neck cancer, and it will be different for each cancer actually. So the needs would differ, the requirement of or input of people from supportive care, for even the supportive care team will not only have palliative medicine specialist or symptom management specialist, they will have nutritionists, they will have rehab specialists, they will have swallowing therapist, speech therapist, and a lot of other people, physiotherapists. So it's in a whole a gamut of people managing a single person, and then needs to be a lot of coordination there between the teams. So I believe that is also important when we look at a management, a holistic management of a person like this.
Thank you, Anuja. Yeah, in our quest for integration, we should not fragment care. I think that is something that we need to maintain that holistic balance. And coming to the, so all of us, I think, are in tune that all of these should be available for our patients. But again, the challenge is, are we really able to do it? Because do we have enough trained people anywhere to do this? Which brings us to the second part of the panel discussion, which I would just like to highlight, where which is about education and training in palliative care. So I think a lot of our speakers in medical oncology, both of them, so Deepa as well as Avinash, they and also Dr. Malhotra, focused about the importance of integration of palliative care, but especially Avinash and Deepa also mandated about palliative care training in oncology residency and clinical rotations in both, whether between oncology and palliative care. Like we request the oncology residents to work in palliative medicine, I also feel it's important that palliative medicines rotate in oncology. So I'd just like that we could discuss this aspect here. So could we start with you, Anuja?
So about training and education, definitely we need some kind of rotations of palliative medicine and oncology to each branch. But then one thing I feel it's already integrated in oncology, as well as I believe there is an element of palliative medicine training in oncology training, as well as an element of oncology in palliative medicine training when we look at the curricula. But one thing that is missing somewhere is how to work as a team. So apart from the fact that we learn about the subject, I feel also learning about how to work as a team is extremely important. So I believe education and training is in the right direction. Only thing is we need some things to be added.
Please continue, Anuja. I think we had a disturbance.
Yeah, can you hear me?
Yes, yes.
Yeah, sorry for the interruption in between, but yeah, so I was talking about having some kind of change there in the curricula, which also teaches people to work more as a team rather than working as individuals. So I would say there are already provisions for education and training in both oncology and palliative medicine curriculums, but teamwork becomes extremely important there, and that needs to be integrated somewhere in the education and training.
Thank you, Anuja. Kalpana, do your oncology residents train with you?
Yeah, while I agree that there is some amount of training that is happening in the oncology curriculum per se, from when those oncologists come to us for training, they find it's a totally different thing. They appreciate the palliative. See, generally we've mandated in our hospital that all our postgraduates go through the IAPC course. So when we come and when we go through a communication module with role play, that's when they seem to realize that, I mean, what is it when a patient actually sits in the chair with a diagnosis of a disease? All those things, I don't think, while there is something in the curriculum, it is not taught the way a palliative care physician would do. It is taught by oncologists. So the perspective of treatment, of teaching for these students of oncology still is focused on the disease management and symptom management, and it is not a multidisciplinary treatment, multidisciplinary way of managing patients, which is the main focus in a palliative care setup. So I think while there is teaching, there's lots to be done, and there definitely the oncologists need to come to palliative care department, need to go through a course run by palliative care physicians for them to understand the nuances of what palliative care is and perceive it when they see patients being seen by a palliative care physician, rather than how they break news or how they do, while not taking away anything. I have had feedback from some of the oncologists, some of the radiation oncologists and medical oncologists who are practicing, and when they go through the course, they're very happy with the course. So I think it's a different perspective on looking after the patients, which need to be, inculcated, is what I would feel.
Thank you, Kalpana. That's what we often feel, that they appreciate palliative care, but whether they are empowered to do it or give it to their patients, that is where the question is. Dr. Shabani?
I agree with what both Dr. Kalpana as well as Dr. Anuja said, but I would also try to talk from the oncologist's point of view. Most of us oncologists, when we are treating the patient actively, at least when we think we are giving curative treatment, we feel we can manage the symptoms best, So that's the kind of attitude that we have, which is wrong several times, because what happens is the patience, the time that is needed to actually give to a patient and understand, there may be the same kind of reactions that we see in two patients may not be the same. And the reaction of the patient or the family to that same reaction is not the same always. And therein, I think, is a very important role played by the entire palliative care team. See, it's not only the physician in the palliative care team that is important. You have the other members of the team who play a very important role, I think. And that is something that we as oncologists, we really don't have the luxury of, taking recourse to. So that is why it is important for us to realize what it is that we don't have, even during the active treatment phase, and why we then need to refer the patient early on itself when we're giving curative treatment to the palliative medicine team. I wish all of us really had the luxury with work, because just now we really think about it as end of life. But yes, we have begun to realize that it has to be done early on. But do we have the luxury? And hence, it is even more important to be able to, work as a team towards this end. So that if you have a palliative medicine specialist in your team, if you have them in our team, it is easy for us to then deal as a group, rather than just have one person being responsible for the entire thing. That's my take on it.
Thank you, Sharbani. That's why it would be nice to have a rotation where a palliative medicine person is posted in your head and neck group itself. Kalpana has raised her hand. Yes, Kalpana?
Yeah, while I agree with everything that Dr. Sharbani says, the other thing that I truly feel is there should be, I'm not saying that oncology should be the primary palliative care physicians, but in a big institution, there has to be a specialist palliative care and a primary palliative care. And the oncologist should be doing the work of a primary palliative care. And, refer when you, specialist palliative care, there should be a trigger when you decide that this is when I want to refer the patients for, specialist palliative care. And that should happen across the oncology hospitals. We should strive for a clear, referral pattern so that it's uniform across the country. So I have been in lung cancer, I find early palliative care is one of the, in the guideline it comes. But in the others, there is palliative care symptom treatment, palliative care radiotherapy. Why not have a clear, link between the two of a standard way of, standardized care pathway of something where we can integrate the two.
Thanks for bringing that up, Kalpana. In fact, we were hoping that the trigger from this session would be to some kind of a consensus or guidelines between oncology and palliative care, if you have the teams from the country, and through NCG, if that can be done as triggers for referral and primary palliative care specialists, I think it would be a great standing point. Anshika, I can see your hand, and Sharbani. So Anshika, you could go first.
So I really take all the points very well. I'm a surgical oncologist and I went for a palliative care training through the CTC course. And from and that was around 14 months, focused training for a few days and then thereafter repeated training periods. And then I took the online palliative care courses. I've taken IAPC course. So I have actually gone out of my way to train myself in palliative care. And that's because I could see the benefit of that how much benefit and the consultants who are already working with the cancer patients, there are ways to go for training. One can go for small steps and then larger steps, but eventually you will end up including palliative care in your clinical practice and help the patients a lot. The second point, ma'am, I wanted to make is in our center in Dehradun, CRI, Cancer Research Institute. So we do AMEs and palliative care programs where all the oncologists, the nurses and the residents, we take them through various aspects of palliative care on a regular basis. And that's how we probably expect each one of us to be the primary palliative care physician. And then if there are some trigger referral points, refer to the specialist palliative care department. And it has really helped our patients a lot with early integration of palliative care.
Thank you, Anshika. And thanks, Sharbani. You could please conclude the session with your remarks.
So I kind of agreed with what Dr. Kalpana said, about having the oncologist spend time and understanding the nuances of palliative care, if I may say so. But at the same time, I think what you call Avinash, in his last slide, which was a very important slide, which alluded to the barriers as to why we as a country or we as a team have not adopted palliative care the way it should have been, I think those are very important points to note. And if we could work on each aspect of the several points that he raised, we may be able to achieve something towards achieving this goal of, realistic integration. It's good to talk about it. It's good to be, you want to do it. It's not like none of us want to do it. We want to do it. Because it would take a lot of things off our shoulders and the patients would be really benefited, because the psychosocial aspects, which of us oncologists spend time with it? None of us, if you ask me, because we're not even trained. And we really don't have that time to give to our poor patients. So these kinds of things definitely would be aided if we were to look at the barriers which today prevent us from actually going on to effective integration. And as Dr. Kalpana alluded to the point that lung has a mention of early integration of palliative care, and perhaps that emerges from the fact that you've got level 1 evidence from Temel's trial that's saying that there has been an advantage even in overall survival. Unfortunately, the randomized trial done in India was negative for palliative care in head and neck cancer. So having said that, we sometimes feel that maybe the non-modifiable socioeconomic factors have a very significant role to play in our patients. And that is why the role of palliative care may be even more important. And also our patients do not formally go through the standard care pathways. The criticism for Jennifer Temel's paper was that they saw this improvement in overall survival primarily because it was a specialized unit looking at lung cancer and lung cancer as well as cancer care as in general. So that is one of the things that is also lacking. That the formalization of any kind of standard care pathway. So that's my other take on why we don't find positive, though we know it is important, we realize it is important and still don't find the trials giving us those answers.
Thank you so much, Tarbani. I think all of us are struggling with that, but I hope that with this session, we will be able to take this forward with some kind of consensus for creating synergy between oncology and palliative care. I think we've started the work, it's for us to take it through. And Avinash is right here with me. And Deepa, I can see her on the screen. I'm really sorry I can't have any of you all talk because your organizers will just shoot me. It's 2:32.